welcome to Medicine Grand Rounds. It's my privilege today to introduce Cam Patterson, who I suspect really doesn't need an introduction to this group, but probably needs an introduction to some of our friends in Wilmington. Cam is the Ernest and Hazel Craig Distinguished Professor of Cardiovascular Medicine. He's chief of our Division of Cardiology, and he's director of the new UNC McAllister Heart Institute, which some of you, I think, are familiar with. Cam completed his medical training at Emory. He then did a residency in internal medicine at Emory. Following residency, he was chief resident there, and then went to the Harvard School of Public Health, where he did a fellowship in cardiovascular biology and did more cardiovascular training at UTMB. And in one way or another, he ended up at UNC, and we've been very happy to have him here. His research involves the use of molecular, genetic, and physiological approaches to investigate cardiac failure, atherosclerosis, and angiogenesis, among other things. And his topic for today is the genetic testing in cardiovascular disease.
So it's my pleasure to be here. I know that all of you are busy, and I'm very grateful that you have asked me to talk about something that I think is a really important topic. I know what a lot of you are thinking when somebody like me steps up to the microphone. Is he ill-prepared? Is he going to give a wonky basic science talk that's irrelevant to me? Is this going to be some obscure aspect of cardiology that doesn't pertain to what I do? And whenever I talk to an audience like this, I'm reminded of a quotation. Here comes the orator with his flood of words and his drop of reason. It's a quotation by Benjamin Franklin, and I think it's the kind of thing that we want to avoid. I'm also reminded of another quote. Somebody has to say something, and it's just incredibly pathetic that it has to be us. And that, of course, is a quotation by Jerry Garcia. So I'd like to begin just by placing what I'm going to talk about in perspective, and I get my best medical information from Wikipedia. And Wikipedia tells us that the father of medical genetics was Gregor Mendel. He made seminal discoveries about the transmissibility of phenotypes in the late 19th century. And I think it's really remarkable that in less than a decade of time, we went from that initial fundamental discovery of genetics to the completing of the Human Genome Project. I think that the Human Genome Project really marks a fine demarcation in the field of genetics. And one way that I like to think about this is that the Human Genome Project tells us about what makes us all the same. And I think the rest of the history of genetics is going to be telling us what makes us all different. What I'd like to do today is to tell you about three diagnostic applications of genetics in the field of cardiology. The use of genetics to diagnose heritable diseases, identifying genetic risk of disease, and predicting drug responses. And I think that this spans the majority of clinical applications of genetics, but I also think that these three topics illustrate where genetics is applicable clinically now and where genetics will be applicable clinically in the future. And I think that in each of these three areas, we're at very different places in terms of our clinical applications. So I'd like to begin by talking about diagnosis of heritable diseases. There are a number of heritable cardiovascular diseases, including long QT syndrome, familial dilated cardiomyopathies, et cetera, et cetera. But the disease that I want to talk about today is hypertrophic cardiomyopathy. And I think that everyone is aware of the phenotypic manifestations of hypertrophic cardiomyopathy. Initially, there's a thickened left ventricle, frequently asymmetrical. Over time, the ventricle may eventually fail, lead to congestive heart failure. More commonly, adverse clinical outcome of hypertrophic cardiomyopathy is sudden cardiac death due to ventricular arrhythmias. It's the most common cardiac genetic problem that we encounter. Its prevalence is 1 in 500 individuals. I think, importantly, the natural history of hypertrophic cardiomyopathy is extremely variable, and the risk of sudden death in individuals with genetic hypertrophic cardiomyopathy ranges from less than 1% to over 10%. And obviously, predicting someone's risk of sudden death is extraordinarily important in these patients, because if the risk of sudden death is 3% or greater, then the patient obviously needs a referral to Paul Mounsey or one of our electrophysiologists for implantation of cardiac defibrillator. And if the risk is 1%, then the patient probably doesn't need such aggressive management. Importantly, the number of mutations that have been found that cause hypertrophic cardiomyopathy continues to increase, and is now over 300 mutations in about 15 different genes that will result in hypertrophic cardiomyopathy. Most of the genes that lead to hypertrophic cardiomyopathy are genes that encode for proteins that are contained in the cardiac sarcomere. And for reasons that are still obscure to us, specific mutations in sarcomeric proteins are ultimately what results in the clinical phenotype of hypertrophic cardiomyopathy. Now, I think that genetic testing, which is now available for these mutations, can be helpful for your patients with hypertrophic cardiomyopathy, or for your patients who might have hypertrophic cardiomyopathy, for 4 different reasons. One of these is to risk stratify patients. I talked about the variability in the risk of sudden death in patients with hypertrophic cardiomyopathy. Secondly is discriminating classical hypertrophic cardiomyopathy from other diseases that phenocopy hypertrophic cardiomyopathy. Third is defining risk in family members of patients with hypertrophic cardiomyopathy. And finally, genetic testing can be useful in clarifying uncertain phenotypes. So I'd like to first talk about risk stratification. The phenotypes, both in terms of the amount of ventricular hypertrophy and the risk of adverse outcomes, including sudden death, varies. And it turns out that that variance depends very much on the specific genes that are mutated in patients with hypertrophic cardiomyopathy. So, for example, patients who carry mutations in myosin-binding protein C are among the most common patients with hypertrophic cardiomyopathy that we see. And so long as they don't have a truncation mutation, so long as they simply have a missense mutation, the amount of hypertrophy that these individuals tend to get is fairly small, and the outcomes of these patients are exceptionally good. Sudden cardiac death is very rare in hypertrophic cardiomyopathy patients with myosin-binding protein C mutations. In comparison with this, patients with mutations in troponin T have a very similar phenotype with respect to the ventricle. It's a very mild hypertrophy that these patients get, but their incidence of sudden cardiac death is extremely high, on the order of 10% or greater. And again, in contrast to both of these situations, patients with mutations in beta-myosin heavy chain have an extremely thick ventricle, and they tend to get both a lot of heart failure and a higher incidence of sudden cardiac death. So if you have a patient who comes into your clinic who has hypertrophic cardiomyopathy, one of the things that you need to tell your patient about is, what is my risk of adverse outcomes, in particular sudden cardiac death? And it's possible to predict that based on family history and other features, but I think that the best index that you can use to predict sudden death is the specific gene that is mutated in your patient. So a second reason to do genetic testing is to discriminate classical hypertrophic cardiomyopathy from overlap syndromes that phenocopy hypertrophic cardiomyopathy. And there are a number of these that exist: glycogen storage diseases, lysosomal storage diseases, that all manifest with a very thick heart, but that don't have the same attendant incidence of sudden cardiac death, and very frequently have other associated features that will impact the patient's well-being. And an example of this is the constellation of hypertrophic cardiomyopathy, Wolff-Parkinson-White syndrome, and atrial fibrillation that was discovered a few years ago by Bob Roberts in a family that had mutations in a protein called AMP kinase. AMP kinase is a master regulator of energy in each of our cells. And as you would imagine, if there's a mutation in this protein, not only do these patients get hypertrophic cardiomyopathy, but these are a class of patients that very frequently evolve into dilated cardiomyopathy and low output state at an early point in life. So understanding the distinctions between this syndrome and classical hypertrophic cardiomyopathy helps us very much to manage these patients, both because we need to be on the lookout for arrhythmias, because some of the treatments that we use for classical hypertrophic cardiomyopathy are contraindicated in patients with Wolff-Parkinson-White, and because the outcomes of patients with this clinical situation are very, very different from patients with classical hypertrophic cardiomyopathy. Another disease that we see occasionally that mimics hypertrophic cardiomyopathy is Danon syndrome. This is an X-linked disease that includes hypertrophic cardiomyopathy, muscular dystrophy, and particularly in males, some degree of mental retardation. This is a disease that's caused by a lysosomal storage disorder, and it's important to recognize this disease because since it's X-linked, males are much more highly affected than females, and that can be something that's important to keep in mind as you manage the whole family. Now, a third reason to test for hypertrophic cardiomyopathy is to define risks in family members, and this is probably what we spend the majority of our time working on as we manage patients and families with hypertrophic cardiomyopathy. And this is an example of a pedigree that we collected that I think illustrates this point. This was a young female, I believe in her 40s, who was referred with hypertrophic cardiomyopathy. She has a large family, and the question is which of the other family members need to be screened for hypertrophic cardiomyopathy. Obviously, her brother and sister need to be screened because they have a 50% chance of having the same clinical syndrome, but does anybody else in the family need to be screened? When we evaluated the mother and the father, both of them had some degree of left ventricular hypertrophy. Both of them also had hypertension, and the mother actually had more hypertrophy than the father. And our thinking was that the mother was actually the family member that was the parent who passed the aberrant allele on to her daughter. But when we performed genetic testing, it turned out that it was actually the father who was the carrier. And if you look at the pedigree, you can see up at the top that the father's father died at age 47 suddenly, and so he probably was the founder in this family. We now know that we actually need to screen everybody, all the blood relatives on the father's side of the family, because they all are at increased risk of having genetic hypertrophic cardiomyopathy. So without having genetic testing, we really would not have known how to manage this patient. And this is a problem that comes up over and over again. I think one important issue when we talk about screening family members or performing genetic testing for hypertrophic cardiomyopathy for any reason is what is the cost of the test, and how are we going to get this paid for, and what resources will we need to screen a family like this. And I'll just tell you that the testing of the founder patient that you have is very expensive. It's going to cost several $1,000s. It is often, but not always, covered by insurance. Now, there have been several new companies that have entered this market, and I believe that that's going to drive the cost down. There are also companies that have very clever pricing. There's one company, Cardiology, which charges a small fee, of about $200 or $300 for testing, and then they themselves will bill insurance for the genetic testing. So the insurance would pay them directly. The patient and the healthcare system are not at risk if the insurer decides not to pay. I'll also point out that once you know the mutation that is present in a family, the remainder of the screening is actually very cheap, on the order of $150 to $200 for the other family members. So the cost becomes less of an issue under that circumstance. Now, the last situation where we sometimes perform genetic testing for hypertrophic cardiomyopathy is in clarifying uncertain phenotypes. And I think a case that illustrates this is Evander Holyfield. I recall when I was in my training at Emory that Evander Holyfield fought for the heavyweight championship against Michael Moore in Atlanta. And he actually developed heart failure during the bout and was brought into the emergency room at Crawford Long Hospital, was evaluated thoroughly, and he was found to have a small PFO, but a dramatically thickened left ventricle. He was diagnosed with hypertrophic cardiomyopathy and told that he should never fight again. And this was reported in Jet magazine in May of 1994. And about 8 months later, Jet magazine reported that Mr. Holyfield sought a second opinion at the Mayo Clinic. He was evaluated there, and they told him that everything was fine. His heart was a little bit enlarged because he was a highly conditioned athlete, and he didn't need to worry about any future problems. And so the question becomes, what is actually going on here? And this is a situation that we are confronted with frequently. As many of you know, highly conditioned athletes, especially endurance athletes, cyclists and swimmers, very commonly have a significant degree of left ventricular hypertrophy. There are some features that differ between what we call exercise heart and clinical hypertrophic cardiomyopathy. The amount of ventricular thickening is frequently less. It's symmetrical. Frequently there's a degree of chamber dilatation that's absent in hypertrophic cardiomyopathy. But it's not uncommon for us to be in a gray zone where we're trying to determine whether this is a heart that is remodeled because of exercise or a heart that is abnormal for genetic reasons. And it turns out that the heart is actually a highly plastic organ, and activities like endurance exercise can certainly modify the shape of the heart. And I think that we probably spent too little time in medical grand rounds talking about snakes. The Burmese python feeds about once every 6 months. And after it feeds, its heart increases in size or mass by about 50%. And that's to provide additional cardiac output to assist the gastrointestinal tract with digestion. Over time, the heart then regresses back to normal size until the python decides to eat another small pig again, or whatever it is that it happens to find out in the jungles of Burma. And I think this is a great example of the fact that the heart can increase in size, not because of any genetic reason or because of any pathology, but simply because the heart's responding to other cues. This is, I think, a really important issue and becoming increasingly a topic of interest in the news, and certainly a topic that we get confronted with frequently, and that's making the distinction between a heart that's abnormal because of exercise, which we don't uncommonly see in highly competitive young athletes, and a heart that's abnormal because of hypertrophic cardiomyopathy that puts an athlete at risk for sudden cardiac death. And it's important to keep in mind that about 40% of cases of sudden cardiac death in young athletes are due to hypertrophic cardiomyopathy. So this is not a trivial distinction to be made. And as I mentioned before, there are certainly situations where it's easy to tease out whether or not an enlarged heart is due to the fact that the individual is a competitive athlete or whether the enlarged heart is due to hypertrophic cardiomyopathy. There are some clinical features that we can use to help make this distinction. Certainly if there's a family history, that points strongly towards hypertrophic cardiomyopathy. If you can convince the athlete to stop exercising for a while and then reassess the patient and the hypertrophy has regressed, that clearly indicates that this is an exercise-induced hypertrophy, but good luck doing that. I haven't had much success. You can see bizarre electrocardiographic features in either of these, so that really is not a big distinction. Unusual patterns of hypertrophy, septal or apical hypertrophy, is a strong indicator that the situation is a case of hypertrophic cardiomyopathy. But very often we still end up in a gray zone where we don't know whether this is an athlete who can continue to do what they're doing or an athlete who is at high risk of sudden death. And so in that situation, I think that genetic testing can be extraordinarily helpful in helping to tell a patient and their family whether it's safe to continue their athleticism. So I think that testing for hypertrophic cardiomyopathy and a few other diseases, long QT syndrome for certain, are diseases in which genetic testing is available, it's well established, and it's clinically extremely useful. And I think that when you see a patient with hypertrophic cardiomyopathy, I almost think that you need to ask yourself why you wouldn't do genetic testing in this patient rather than why you would do genetic testing in such a patient. Now, there are other situations where I think we're still kind of up in the clouds in terms of how to apply genetic testing, and I think a An important one of these is atherosclerosis. I think we all know that coronary artery disease is a familial disease. Certainly it's an important part of our history and physical examination when we're evaluating patients. And for many years, it seemed that there was this recurring phenomenon that someone would report in the biomedical literature that they had found a gene that led to atherosclerosis, and a few years later, somebody would report that they tested that discovery and found it to be a red herring. But there is no doubt that atherosclerosis is a familial disease, and I think the best data for this are the Northern European twin studies that have been done. And this slide is a little bit complicated, but I want to talk you through it. So basically, what you're looking at is survival probability in one twin when the other twin has died of a myocardial infarction. And the black line on each of these is the survival probability for our entire population. So if you look at the upper left-hand side, if you have a twin whose other twin died before the age of 55 of myocardial infarction, whether they were a monozygotic or a dizygotic twin, their risk of dying early was greatly increased. And in fact, that risk persists even up until the time that the other twin died before the age of 75, which you can see in the upper right-hand panel. So the genetic risk of dying of cardiovascular disease is conferred when any twin, or any family member actually, has cardiovascular disease before the age of 75. I think what's also interesting about these studies is that the opposite is also true. If you look at the middle bottom panel, if a twin dies at greater than the age of 86 of a myocardial infarction, the other twin is actually conferred a longevity advantage and is more likely to live longer than the rest of the population. So there are genes that both confer an increased risk of cardiovascular disease and a decreased risk of cardiovascular disease. And since cardiovascular disease is the #1 cause of death and disability in our society, you can see the impact on this in terms of longevity, both in a positive and in a negative direction at a population level. Now, in spite of the fact that there's such a strong genetic component to cardiovascular risk, as I mentioned, we've been struggling to actually identify specific genes that conferred an appreciable risk of cardiovascular disease. And I think my rationalization for why this is because there are so many genes and pathways and signaling molecules, et cetera, that participate in the atherosclerotic process. And so I would tell people even a couple of years ago that the reason why we don't have genetic testing for atherosclerosis is that the risk conferred by any single gene or any single abnormal allele is very, very, very small. And that all changed just about a year and a half ago with a simultaneous publication by 4 different groups and 4 different populations of a risk allele for cardiovascular disease that was contained on chromosome 9. And I think that the simultaneous identification of the same allele in 4 different populations argued very strongly that this allele, in fact, did confer an increased risk of cardiovascular disease. And so what do you think was the first thing that happened when these 4 studies were published? Well, somebody came out with a genetic test to screen for this, decode diagnostics. This test was literally clinically available within about 3 months of publication of those 4 studies simultaneously. And so you can order this test. You can find out whether your patient is positive or negative for this particular risk allele, and Decode will send you this report that has either positive or negative in very big print, and then a bunch of other small print down below. And I think that many of us, when we're given a piece of paper that has print that's this small on it, probably not going to spend that much time working their way through it. So what I want to do is make it easier for you to read so that you can understand what your patient is getting out of a positive or negative evaluation through this test. whereas about 20 to 22% of the population are homozygous for one or both risk alleles. They have both of the risk alleles. A much lower proportion of the population than that has experienced symptoms of coronary heart disease by age of 50 for men or 60 for women. Therefore, a positive test does not mean that an individual will develop symptoms of coronary heart disease by this age, or for that matter, even later. And this is, I think, the kicker. In the same way, the prevalence of a negative test among individuals who have had MI is about 75%. So that is, people who have known coronary artery disease, only 25% of them carry this risk allele. And I think that the question becomes, what information do you actually derive clinically from knowing that your patient carries this risk allele? And I think as we try to look into whether this risk allele actually confers additional clinical information, the jury is clearly still out. Data from the ERIC study showed a small, an extremely small, increase in clinical predictability when you add knowledge of this risk allele to traditional risk factors. But I think a larger study done on the Women's Genome Project, the Women's Genome Heart Project by Paul Ricker, showed that adding knowledge of this risk allele to traditional risk factors actually doesn't confer any additional clinical information over knowledge of the traditional clinical risk factors themselves. And I think that one interpretation of this is that knowledge of that risk allele is already baked into the traditional risk factors that we already collect on our patients. And this actually makes a lot of sense, because Karen Mulkey here at UNC has shown that a strong risk allele for diabetes is actually right next to this particular risk allele. So it may be that this risk allele is simply just a marker for the development of diabetes, rather than a marker that's independent of what we already know about our patients. So I think that this is clearly, atherosclerosis is clearly a big problem for all of us. Predicting risk of atherosclerosis is extremely challenging, even under the best of circumstances. If we can add specific genetic information to our ability to define risk for our patients, it would be extraordinarily helpful. But I think that in marked contrast to the heritable cardiovascular diseases, we're still way up in the clouds in terms of being able to apply genetic testing in this important circumstance. So I'd like to spend the last 15 minutes or so of my talk talking about, I think, a third really important application of genetic testing, and that is the prediction of drug responses. I want to focus specifically on two very common drugs that we use clinically all the time, warfarin and clopidogrel. I think one of the great scientific advances, maybe the greatest scientific advance from a clinical perspective in the 20th century, was the development of the randomized controlled clinical trial. And randomized clinical studies are extraordinarily powerful in helping us to ascertain whether or not drugs are beneficial across populations. And they have obviously had profound effects on clinical practice and guidelines for therapy and cardiology and every other aspect of clinical medicine. But what clinical trials are not very good at is determining which patients from within a population are likely to be responders versus non-responders, nor are they very good at determining which patients within a large population are likely to have adverse outcomes related to a therapy that is initiated. And this is where I think genetic applications, and in particular an approach that we call pharmacogenomics or personalized medicine, can be, I think, very helpful in guiding treatment strategies for patients that we're trying to take care of. And just as an example of a situation where this type of approach could have been, I think, very helpful, we saw a 60-year-old woman who was flying up to see her daughter, had a DVT when she got back, presumably because of the long plane flight, and was prescribed Coumadin at a dose of 5 milligrams by her primary care provider and told to come back in 2 weeks to be reevaluated. And then she presented to the hospital and was admitted a few days later with a massive intracranial hemorrhage. And her PT, her INR obviously was well above the normal range. And the question is, why did she so rapidly become anticoagulated after a relatively modest starting dose of warfarin? So to understand what's going on, I think we need to go back to medical school for a second and talk about how warfarin works. As you probably remember, the clotting enzymes that are responsible for creating a blood clot are only active when they're gamma-glutamyl carboxylated. And the reaction that drives gamma-glutamyl carboxylation of clotting factors requires cofactor vitamin K. Now, in the course of gamma carboxylating clotting factors, vitamin K gets converted to vitamin K epoxide, and this is an inactive form of vitamin K. So the vitamin K epoxide needs to be converted back to active vitamin K, and this occurs through a reaction that requires an enzyme called vitamin K epoxide reductase, or VCOR. And this is the enzyme, actually, that warfarin acts on to exert its anticoagulant activities. Warfarin is also metabolized through the cytochrome P450 system, in particular through cytochrome P450 2C9. And so one would predict that mutations either in VCOR or in cytochrome P2C9 might lead to alterations in the activity of warfarin. And in fact, that's indeed the case. We now know that there are mutations in VCOR that lead to increased sensitivity to warfarin. There are also mutations in cytochrome P2C9 that lead to increased sensitivity to warfarin. And in particular, there are two alleles that confer increased sensitivity to warfarin. One is an allele called STAR2 that results in a loss of about half of the ability of 2C9 to metabolize warfarin. And then there's an allele called STAR3 that results in almost complete abolition of 2C9 to metabolize warfarin. So patients with one or both risk alleles with STAR3 are extraordinarily sensitive to the anticoagulation activities of warfarin. And indeed, knowledge of these alleles is actually very important because they have an impact on clinical outcomes. For instance, if you have a 2C9 variant, if one of your patients has a 2C9 variant, it takes your patient about twice as long to get to stable dosing compared to a patient who has two normal alleles. And a patient who has a 2C9 risk allele has about a 4 times greater chance of having a serious bleeding event within the first 2 years after initiation of warfarin compared to a patient who has 2 normal alleles. So these alleles really matter not only in terms of how rapidly you anticoagulate a patient, but also in terms of their clinical outcomes. And when we evaluated this patient, it turns out that the patient had normal alleles in VCOR, but had the 2 STAR3 risk alleles in cytochrome P2C9. And this almost certainly accounted for the fact that she became rapidly anticoagulated after initiation on a relatively modest dose of warfarin. Now, there are a lot of factors that affect sensitivity to warfarin. We are all, I think, well aware of the impact of age, diet, sex, race, etc. But genetics actually makes up about 40% of the determination of an individual's susceptibility to anticoagulation by warfarin. And in fact, there are now algorithms that you can use if you know the genotype of your patient to predict what an initiating starting dose would be. And if you go to www.warfarindosing.org, you can actually plug this information in and predict what your patient's starting dose of warfarin should actually be. And in fact, this algorithm is very, very good at predicting what an actual warfarin regimen should be for your patient based on knowledge of your patient's, simple knowledge of your patient's demographics, as well as the genetics of their VCOR and 2C9 genes. So I think that there's obviously a race now to try to turn this type of testing into something that's clinically available to you as you're managing your patients. Certainly it's something that you can get now, but it takes a couple of days to get results back, and often that's difficult to incorporate that, certainly into a situation in which you're initiating warfarin as an outpatient, or when you're seeing a patient who has a short duration of inpatient stay. So I think that you're going to see evolution of testing for these risk alleles to the point where hopefully we'll be able to have it at or very close to the bedside as we're making decisions about anticoagulating our patients. Now, another situation where we see great variability in patients' responses on the cardiology service is patients that we are initiating on clopidogrel. And it turns out that there's great variation on an individual-by-individual basis in the ability of a patient to decrease their platelet function after a single dose, a specified dose of clopidogrel. And it turns out that this is also determined predominantly based on the individual's genetics. Clopidogrel is an interesting drug because clopidogrel itself is inactive. It's a prodrug, and it has to be metabolized again by the cytochrome P450 system, in this specific case by cytochrome 2C19, to be converted into the active form. And so individuals who do not have a normally functioning cytochrome P2C19 will not metabolize clopidogrel to its active form. Clopidogrel will instead be esterified into an inactive metabolite, and these individuals will be resistant to the actions of clopidogrel. And this is clinically very important. I think a lot of you now know about the interactions between proton pump inhibitors and clopidogrel therapy. Proton pump inhibitors very specifically inhibit cytochrome 2C19. And patients who are started on clopidogrel for acute coronary syndromes actually have much worse outcomes if they are simultaneously on proton pump inhibitors. You can see the upper lines are patients who are not being treated with clopidogrel. If you treat a patient with clopidogrel, the probability of death or occurring ACS is dramatically reduced, which you can see in the kind of the darker gray bar. And patients who are on proton pump inhibitors lose about half of the protection from clopidogrel because of the ability of the proton pump inhibitor to prevent clopidogrel from being metabolized into its active metabolite. And so we obviously now are much more concerned and attuned to the use of proton pump inhibitors in patients who are being started on clopidogrel, especially in patients who've had recent stent implantations, because patients who are insensitive to clopidogrel are obviously at high risk of late stent thrombosis, which is the most catastrophic complication of stent implantation. Fortunately, it's extraordinarily rare, but patients who are on proton pump inhibitors are obviously at increased risk of this rare but devastating potential complication. Now, the converse is also true. Cigarette smoking increases the activity of 2C19, cytochrome 2C19, and patients who smoke more than 20 cigarettes a day actually do better on clopidogrel than patients who don't smoke. And this is obviously not an advertisement for smoking, but this may actually be, an example of one of the reasons why cigarette smokers actually do better after acute coronary syndromes than the non-cigarette smokers. So anything that is affecting the activity of the system that metabolizes clopidogrel is likely to be impacting your patient's responsiveness to a very, very important medication. Now, the question then arises, can we use genetic approaches to try to identify whether or not patients are resistant to the activity of clopidogrel or whether they're responsive to the activities of clopidogrel? And the French study that was recently published looked at over 2,000 patients who were admitted with myocardial infarction and started on clopidogrel. Out of this patient population, there were over 200 cardiac events. And then they looked at whether mutations in cytochrome 2C19 or other genes that are involved in clopidogrel actions were predictive of outcomes in these patient populations. And just to cut to the chase, the hazard ratio for patients carrying 2 variant alleles in cytochrome 2C19 was increased 3.5 times in those patients on clopidogrel compared to patients that did not have variant alleles. And so while there's not clinical testing for these risk alleles yet, certainly experimentally here at UNC under the supervision of Joe Rossi, we're beginning to do studies to try to determine whether we can predict whether or not a patient is non-responsive to clopidogrel. And the question becomes, what do you do for these patients if they're non-responsive? And the first thing that people often say is, well, why don't you just increase the dose of clopidogrel? And that certainly it's possible that increasing the dose of clopidogrel may increase the amount of the drug that gets converted into its active metabolite. But it's also just as likely, and certainly this occurs in other circumstances, that increasing the dose simply increases the amount of the drug or the prodrug that goes down the alternative pathway. So knowing the genetics, it may not help us, it may or it may not help us in terms of developing better dosing strategies for clopidogrel. But fortunately, alternatives to clopidogrel are not too far off on the horizon, and it's very likely that an alternative drug, prasugrel, will be on the market here in the United States fairly soon. And the good news about this is that if you compare responsiveness of patients to clopidogrel with responsiveness of patients to prasugrel, you can see that there's no association. So a patient who's insensitive to the actions of clopidogrel is not at increased likelihood of being insensitive or resistant to the actions of prasugrel. And this could be very important clinically if we have testing to determine whether a patient is likely to be a clopidogrel non-responder. Because clopidogrel is about to go off patent very soon. So we can do genetic testing to see whether or not a patient is going to be a clopidogrel responder. If they are, we can leave them on the cheap drug. And if they're not, we know that they need to be on a more expensive drug that's not available generically. And so I think that these types of strategies are the types of strategies that we can apply to our individual patients, not only to determine their specific therapies and to improve outcomes, but also as a way to cost contain how we manage our patients. It's often not necessary to have our patients on all the most expensive drugs or to give them the most expensive treatments. And that's certainly not, should not be our goal as clinicians. So I've talked about, I think, several advantages or applications of pharmacogenomics. I think you're going to see an awful lot of this, but I think that we also still have a lot of hurdles that we need to consider. For instance, in the case of warfarin therapy, there's a relatively urgent need to determine what is the appropriate dose for a patient. And a test that's going to take a number of days to turn around might not be beneficial in some circumstances for your patients. Point of care testing, I think, is going to be critically important for application of pharmacogenomic principles to many, if not most, of our patients. And it's not simply the identification of the risk alleles that will be beneficial to us, but it's the advancement of the technology so that we can offer the information to our patients at the appropriate time. All platforms may not necessarily be universally available to our patients, and that's going to become a critical issue. If the platforms themselves are very, very expensive, healthcare systems are going to have to make decisions about whether or not they can offer all forms of pharmacogenetic testing on site. And again, advancements in technology that make this cheaper are going to be very important in terms of clinical applicability. We have the question where there are multiple risk alleles, which alleles should we screen for? Should we screen for all of them? That's going to be more expensive. Should we just screen for the more common? That may miss some risk alleles in some patients. And these are questions that we don't know the answer to. We're going to have to figure out how to use and interpret the results that we get. In the case of warfarin, I think we already have very good algorithms, but we're going to need to develop those same types of algorithms in every clinical situation. Cost, I mentioned, is going to be critically important. If we can have a relatively expensive test which drives down the cost of the drugs that we give a patient, then I think that this is going to be helpful at a cost level. If this simply adds more information without the opportunity to really benefit your patient, then obviously this is just going to be another drag on our system. And then finally, none of us have trained in an era where this is available to us. I think we're going to have a serious training issue in terms of teaching people about the principles of genetics and their application to our individual patients, or we're going to have experts everywhere who we can refer our patients to manage the information that we're gathering. So I've tried to talk to you about the application of cardiac genetic testing in 3 different clinical scenarios. I would argue that genetic testing is ready for prime time in the heritable cardiovascular diseases such as hypertrophic cardiomyopathy and long QT syndrome. And again, I would make the point that I believe that you really need to ask yourself why you shouldn't get genetic testing in these patients rather than why should you get genetic testing in these patients, because I think the value is so easy to demonstrate. I think there's situations in which we're still way up in the clouds and we don't know how to apply what we now know about the genetics of some diseases, and clearly atherosclerosis is a case in point. Certainly we'll get some clarity over time, but I would argue strongly that even though there are tests that are available clinically to measure risk alleles, I certainly am one person who doesn't know what to do with that information. And then I think there are situations where we're clearly coming out of the clouds. Certainly testing for risk alleles for warfarin sensitivity is a case in point. And I think that we're, especially as we apply genetics to understanding how our patients respond to specific therapies, this is, I think, probably where we're going to see the broadest applicability of clinical genetic testing in cardiology, at least over the 5-year time horizon. So I'd like to finish up with the rest of the story. A few years ago, Evander Holyfield was busted for using human growth hormone. And my suspicion now is, in looking back over what happened to him in 1994, he probably bulked up before his bout with Michael Moore and had a massively thickened left ventricle. And this was the reason why he was diagnosed with hypertrophic cardiomyopathy. He probably went off cycle at that point, and 6 months later was seen at the Mayo Clinic. His ventricle wasn't quite so big, and they told him that he probably just had athlete's heart and he could go about his business. So this is just one more twist to some of the challenges that we face clinically. I'd like to finish up by letting you know that if you do have patients that you think have cardiac genetic problems or that might warrant genetic testing, certainly you're welcome to call us or to refer the patient to my clinic at Meadowmont, where we offer the full range of clinically appropriate cardiac genetic testing and counseling for our patients. I appreciate your time, and I'd be delighted to answer any questions that you have. Andrew? Yeah, so atrial fibrillation, so the question is genetic testing for atrial fibrillation. You know, I think that when we were training, we all thought that atrial fibrillation was one disease, and I think it's now becoming apparent that it's actually a family of diseases that has some common features. And there's a much larger proportion of patients with atrial fibrillation who actually have a genetic cause for their atrial fibrillation than we previously recognized. However, the risk alleles are not well defined. There's not clinically available genetic testing for atrial fibrillation. There's certainly an opportunity for patients that are referred to us to get them into studies to try to identify what is the cause, and hopefully, I think in probably a 2 to 3 year time horizon, we'll be applying genetic testing for atrial fibrillation in much the same way as we're using it for hypertrophic cardiomyopathy now. Other questions? Brian?
Well, you mentioned earlier the way that clinical trials have been designed with randomization for probably a century. Are people starting to change the way these trials are designed so that we don't stop after step 1, which might, in the case of a drug trial, might say X percentage of the patients responded and Y% didn't respond? Traditionally, I imagine we would stop there, but from what you said, it sounds like that really ought to be only step 1, and step 2 ought to be what's genetically different between the 20% of responders and the 80% who didn't what else might we find about those other 80%?
Right. So, so the question for the people in Wilmington is, you know, how can I guess how can we modify our approaches to clinical trials to make sure that we understand not only the broad population benefit but the individual patient benefit? And you know, I would say we have been trying to do that actually for decades. You know, post hoc and secondary and tertiary analyses have been done to try to find out why some people respond and some people don't respond to therapies, et cetera. And you know, I think the statisticians in the room understand how poor that type of approach is, because the more things that you look for, the more likely you are to find something that's simply spurious. I think, you know, the example of people who argue that statins only work in men, you know, because, you know, in one study women didn't have a stronger response is a clear example of, you know, why you shouldn't be, you know, overusing that type of approach. I think that the main difference now in the genetic era that we are able to apply is by including genetic studies baked into the clinical trials, so that we can then screen for risk alleles that might be predictors. And I think, again, it's important to emphasize that finding a risk allele in a clinical trial that predicts an adverse outcome that wasn't a primary endpoint is still only hypothesis generating. And you still need to go back and design a second study to prospectively look at the impact of that risk allele. But it does take us one step further down the road. Other questions? If not, thank you very much.